On behalf of Boulder Community Health, I'd like to introduce our speakers, Dr. Dominik Rog and Ann Brexa. Dr. Rog is a board-certified orthopedic surgeon with a subspecialty in hand surgery. After earning his undergraduate degree from Northwestern University, he received his medical degree from the University of Illinois at Chicago College of Medicine. After completing his residency at Loma Linda University Medical Center, Dr. Rog completed a prestigious fellowship at the Christine M. Kleinert Institute for Hand and Microsurgery in Louisville, Kentucky. The institute was the site of the world's first successful hand transplant, and while there, Dr. Rog participated in a successful double hand transplant surgery. Dr. Rog specializes in numerous conditions that affect the upper extremities, from the shoulders to the fingers, and sees patients at Boulder Medical Center's Boulder and Louisville locations. Ann Brexa has 40-plus years of experience as an occupational therapist. She has a broad clinical background providing occupational therapy services for a variety of neurologic and orthopedic diagnoses. For 18 years, she specialized as a hand therapist and continues to enjoy treating the hand and upper extremities. Ann sees patients at Boulder Community Health outpatient rehabilitation. Welcome to tonight's speakers.
Good evening, everyone. My name is Dominik Rog. I'm an orthopedic and hand surgeon in the Boulder area with Boulder Medical Center. And tonight, we'll talk a little bit about hand and wrist arthritis. What is arthritis? The term is derived from ancient Greek, and it can be translated to joint inflammation or disease of a joint. There are many types of arthritis, including osteoarthritis, autoimmune arthritis such as rheumatoid arthritis and psoriatic arthritis, crystalline arthritis such as that caused by gout, septic arthritis, and more. For the purposes of our talk, we'll be focusing on osteoarthritis. Osteoarthritis is characterized by the breakdown of articular cartilage, also called hyaline cartilage. The picture to the left, this histological image, is healthy articular cartilage. And the image to the right is diseased cartilage with thinning, fissuring, and loss of the actual chondrocyte cells. The end stage of arthritis will be complete loss of the entire cartilage layer. Symptoms of arthritis as it applies to osteoarthritis include pain, stiffness, loss of range of motion of the joints involved, joint swelling, deformity in certain joints that can cause a change in shape, and bumps that are sometimes called bone spurs or osteophytes. There can also be a loss of strength. Most symptoms due to osteoarthritis can be effectively treated without surgeries. These treatments do not reverse arthritis or halt its progression, but are meant to manage symptoms and live with it. This is not an exhaustive list, but certain types of treatments out there are topical and oral medications, supplements, injections, bracing, hand and occupational therapy, acupuncture. Medications include topical medications such as diclofenac. The brand name is Voltaren. There are many oral anti-inflammatories out there, and there's also Tylenol, which is acetaminophen. As far as supplements, there are too many of these for the purposes of this talk, and we could spend a long talk on the subject. There are some commonly used ones here listed called glucosamine and chondroitin and turmeric. And there are also some websites I found that provide some good resources regarding supplement use specifically for arthritis. It is a difficult subject to study, and there is weak evidence for use of many of these supplements, but many are well tolerated and can certainly help. Another treatment are corticosteroid injections, or commonly called cortisone injections. What are these? Corticosteroids are steroid hormones that are naturally produced in the adrenal gland, and cortisone is one of these naturally occurring hormones. The injected corticosteroids that are used for injections are simply synthetic derivatives of cortisone. And some of these are triamcinolone, dexamethasone, and betamethasone. This is the chemical structure of cortisone. Corticosteroids and cortisone are potent anti-inflammatories. Remember that osteoarthritis means joint inflammation or disease of a joint, and these can help with that inflammation. They decrease pain by reducing it. Risks include injection site pain, which is temporary. Certain types of corticosteroids, like triamcinolone, can cause some injection site skin thinning in certain locations. And they have minimal systemic side effects, although they can raise blood sugar in diabetics transiently. I included this slide because this is one of the most common questions regarding cortisone injections I get. Is there a risk of arthritis progression? This subject has been studied mostly in arthritis of the knee, and the jury is still not out. Some studies show risk of progression, some do not. These studies use radiographs of knees and measures of joint space narrowing as a surrogate measure of arthritis progression. I don't think it's particularly applicable to arthritis of hands and wrists because arthritis in hands and wrists often is at its end stage when it becomes symptomatic. These are some alternative treatments in the biologics category are things like platelet-rich plasma. Both of these are typically utilized as intra-articular injections, which means that they're injected into the joint. There's decent evidence for effectiveness of PRP, or platelet-rich plasma, in the treatment of knee arthritis. And you can translate that same research to arthritis of hands and wrists, and I think it certainly has a place. It is, however, not covered by insurance. Stem cells are a promising new treatment. The technology is still in its infancy, and there isn't a lot of long-term clinical research. It's also not covered by insurance, and it can be quite a bit more expensive than even PRP. Another alternative treatment is something called hyaluronic acid, also termed viscosupplementation. This has actually been around for a while. It was first FDA approved in 1997, and it's widely used in arthritis of the knee. Unfortunately, it's not covered by insurance for any other joint besides the knee. So typically when it's used for other joints, you have to actually purchase the vial. I don't think it works as well as cortisone, but it certainly has a place in the treatment of certain joints, especially as an cortisone alternative, and it can be quite a bit cheaper than either PRP or stem cells. Hand therapy certainly has a place in the treatment of hand and wrist arthritis, both physical therapy and occupational therapy. It can be a very useful adjunct, and I'll let Anne speak to us a little bit more about this topic in a little bit. Bracing can be helpful in certain joints. It's not practical in others. Custom splints can also be made by hand therapists. I'll mention some specifics when I go through each individual joint. These are just some examples of splints I found online. Now I'll speak about individual joints. We'll begin with the distal interphalangeal joint, which is the joint between the distal phalanx bone and the middle phalanx bone. So this is the joint here. It's involved in flexion and extension of the fingertip. Distal interphalangeal joint arthritis is characterized by loss of motion. Many patients will often develop these characteristic bone spurs that are called Heberden's nodes, and they show up as two bumps at the top of the joints. Some patients can develop an angular deformity, which would be characterized as a bend this way. Arthritis here is fortunately not always painful. It has a strong genetic contribution. Between 48 and 87% of arthritis at this joint can be genetically contributed, so it's often not really wear and tear, it's just genetics. These mucoid cysts are common masses associated with DIP joint arthritis, and I included this because this is something I see quite a bit in the office. It's basically joint fluid that's made its way outside of the joint capsule of the irritated and arthritic joint, and will show up as what looks like a fluid-filled bump over the top of the joint or knuckle. Drainage, unfortunately, doesn't really work for these joints, for these masses, because of the rapid recurrence. A surgical excision can be performed in the office, and it is often performed because they can be irritating. They can sometimes cause a nail deformity or a groove in the nail when they occur close to the nail. They are benign, and if they're small, can certainly be left alone. But if they are symptomatic, they can be routinely removed in the office. Regarding surgical distal interphalangeal joint arthritis treatments, these are generally reserved to fusion and arthrodesis, which basically means that you stop the joint from moving. It's effective for pain and it will fix an angular deformity, but with the downside of the joint no longer moving. This was a slide of a technique of fusion with a small screw. Another treatment that can be utilized, and something that I do utilize, is something called a chylectomy, which is a bit of a fancy way of saying the removal of bone spurs. In my hands, it's generally used when patients have very large bumps over the joint that are painful when bumped or in the way. It's not as reliable for pain relief, but it can help when those bone spurs are particularly painful. Move on to the next joint, which is called the proximal interphalangeal joint, or the PIP joint. And this is the joint between the middle phalanx and proximal phalanx bone, which is this joint right over here. This is the middle phalanx, this is the proximal phalanx, and its main job is flexion and extension. It has more motion than the PIP joint. Arthritis of this joint is characterized by loss of motion or stiffness at that joint, which can have a greater effect on hand function just because it moves quite a bit more than this joint above. Bone spurs can occur. They're named Bouchard's nodes when they happen. Angular deformity can certainly happen, as in this image right over here. They can have a genetic contribution as well, but they can also be post-traumatic, such as after a prior dislocation or fracture. Surgical treatments for PIP joint arthritis involve either fusion or replacement. My preference is generally replacement because it preserves motion in the joint. Fusion can be more reliable in certain scenarios. Some may argue in the index finger it's more reliable because of the greater pinch forces acting on the index finger, and also in certain cases of instability or significant deformity that can't be fixed with the replacement. These are two different surgical examples of a fusion. The main risk of fusion is the fusion not happening, also called a non-union. In my hands, replacement is done with a silicone implant. Here's an example of an arthritic joint here, and replaced with the silicone implant. There is a type of replacement made out of a product called pyrocarbon that can also be utilized, but it has a higher complication rate. Most patients can recover the same range of motion in their joint as they had pre-surgically, and these implants survive at about 90% at 10 years. We'll move on to the next joint, which is the metacarpal phalangeal joint, also often called the knuckle. It has a little bit of more motion than the other two joints because it's involved in flexion extension, but also radial and ulnar deviation, and it has a little bit of rotation as well. Arthritis of the MP joint is characterized most often by loss of motion and pain with grip. Bone spurs can occur, but they're usually not as visible as the other two joints that we mentioned, and it most often appears as swelling of the joint. There's usually not too much deformity here, and this arthritis typically starts with the index finger and moves outward toward the pinky. These x-rays here are showing examples of metacarpal phalangeal joint arthritis with a complete loss of joint space. Surgical treatments for arthritis of this joint also involve either fusion or replacement. Replacement is my preference, again, because of the preservation of motion, and my implant of choice is silicone. Fusion can also be performed, but in very specific scenarios. This is an image of an article showing excellent implant survivorship when done for osteoarthritis with a silicone replacement at about 97%. A special joint is the thumb metacarpal phalangeal joint. due to the amount of force acting on it. It unfortunately does better with fusion. This is effective for pain relief, but it will no longer move. Due to the loads placed on the thumb, a replacement would have a very high chance of instability. Now we'll move on to the joint below. Now this is more in the wrist. This is the thumb carpal metacarpal joint, which is the joint right over here. It's the joint between the thumb metacarpal and the trapezium bone below it in the wrist. This is a saddle type joint, so it's very mobile. It has many degrees of freedom. This joint can perform flexion extension. It can adduct and adduct in several planes, and it can also rotate. And when combined, these motions allow the thumb to oppose to the other fingers in the palm, also called opposition. Thumb CMC arthritis is very common, and is one of the most common visit complaints for many hand surgeons. A lot of patients come in due to pain at the base of their thumb over here. That's typically the most common complaint. It's often activity related, with activities that involve pinching or gripping. This time of year, gardening would be a culprit. Anything that involves pinching or gripping with the thumb, such as opening a jar, would often do it. Eventually, one can have a change in appearance of the thumb metacarpal base as well. And in these scenarios, the thumb base can become more prominent, as in these images here. And the arthritis can also cause the thumb to pull into the palm, which is termed an adduction contracture. So the thumb will start to appear like this, pulled into the palm. And over time, the metacarpal phalangeal joint can start to hyperextend, and it's called a Z deformity. And that's actually somewhat common in arthritis of these joints. There are some bracing options that can work for arthritis at this joint. This is an example of a splint called an opponent splint that can be made by a hand therapist. This is an example of a soft neoprene splint, and there are many other off-the-shelf splints available. You basically have to find what works for you for this joint. Surgical treatment options for this joint I would consider as a joint reconstruction. Almost all these methods involve removing that trapezium bone, which is called a trapeziectomy. When that bone is removed, you take away the arthritic joint surface. The different variations of this procedure are what I put in parentheses here. There are many variations, and they all involve doing something to help suspend that thumb after that bone's taken away. All the different procedures out there seem to work equally well for arthritis in this joint, and I'll share with you what my preference is. These are just 3 different versions out there. My preference is a procedure called a suture suspension plasty. So again, the trapezium is removed, and then 2 tendons that are attached to both the thumb metacarpal and the index finger metacarpal are then tied together. And this creates a bit of a sling for the thumb metacarpal base. It helps support it, and it also creates an inner position in that space, so the thumb doesn't rub the bone below. This is an image of another procedure that I occasionally utilize, which involves placing an inner position implant into that space, and it's done in specific scenarios. The post-operative protocol after this procedure involves the thumb being immobilized in a splint of some sort for about 8 weeks total. It's usually 1 to 2 weeks in a plaster splint, and then the remainder of the time is in a custom removable brace made again by a hand therapist. I don't use a cast for this procedure. This allows patients to shower and wash their hands after that custom splint is made. Return of grip and pinch strength can be expected in 4 to 5 months, and it will return to the baseline. It will not be that of a normal unaffected thumb, but at the trade-off of being able to do this without pain. There are other options out there, performed I think more rarely, such as fusion and replacement. Fusion works well for pain, but it's not my favorite because of the importance of motion of that joint. There's another form of arthritis that can occur in the joint right below the thumb CMC joint. This joint is the joint between the scaphoid, trapezium, and trapezoid bone, and for short it can be called the STT joint. So this is arthritis of the STT joint. Isolated STT arthritis is much more rare than thumb CMC arthritis, but again, I usually see it with arthritis of the thumb CMC joint. This is an image of a patient with isolated STT arthritis. In that scenario, there can be a deep pain on the thumb side of the wrist and in the palm, and it will often be worse with activity. The STT arthritis I see about 90% of the time is associated with CMC arthritis, so the trapeziectomy procedure will effectively treat this form of arthritis because it will remove the arthritis in the joint below. For isolated STT arthritis, a fusion can be performed, or excision of the top portion of the scaphoid bone can also be performed. Now we'll move on to an overview of some arthritis in the wrist joint itself. Before we do this, I'll do a brief overview of the wrist joint because it can be a little complex. There are 8 main wrist bones or carpal bones, and they effectively form 2 rows. The pisiform bone is right behind the triquetrum, or in front of it right here, which is why you only see 3 in this row. So these 2 rows effectively form 2 joints. One joint is called the midcarpal joint, and the other one's called the radiocarpal joint. They both combine to allow for flexion and extension at the wrist, as well as radial ulnar deviation, and there's a little bit of rotation as well, not too much. There are also joints between each of these individual bones, so it can be a bit of a complex joint. The most common kinds of osteoarthritis of the wrist are something called slack and snack arthritis, which are generally considered a post-traumatic type of arthritis. Autoimmune and inflammatory arthritis can certainly affect the wrist, and it is something that we see as well, but for the purposes of our talk, we're sticking to osteoarthritis. Slack arthritis stands for scapholunate advanced collapse, and the reason for the name is because it happens after a ligament between these 2 bones, the scaphoid and the lunate, tears. Now this can happen in a fall. Sometimes the exact cause isn't known, but 5, 10, 15 years later, it will lead to this form of arthritis. There's another version called the snack arthritis, which stands for scaphoid non-union advanced collapse, and that happens when a scaphoid fracture isn't treated and doesn't heal, and then again leads to arthritis. It usually starts with arthritis between the radius bone and the scaphoid, and then can progress to arthritis in the midcarpal joint, as in this image right over here. The most common symptoms will be loss of wrist motion. There will be pain with activity, especially activity that involves loading the wrist with it extended, as well as swelling on this part of the wrist, the top and palms, and the thumb side of the wrist right over here. Surgical treatment for slack and snack arthritis involve either something called a proximal row carpectomy, which involves removing those 3 bones that I mentioned, and then transforming the wrist into a single joint with the capitate articulating onto the radius. If the capitate head is arthritic, it can also be replaced, and it creates a half-replaced joint. A partial wrist fusion also exists as a treatment for this. It's also called a 4-corner fusion, and it involves removing the scaphoid bone and fusing the 4 remaining bones left. And it also transforms the wrist into a single joint with the lunate articulating onto the radius. Both techniques lose about 50% of wrist motion because you're effectively eliminating one of those wrist joints. My personal preference is the proximal row carpectomy due to its shorter recovery and slightly lower complication rates. There's an alternative to PRC that I sometimes utilize, and it's a procedure called a partial wrist denervation. At about this point in the wrist, there are 2 nerves that have done all their work and now only transmit pain from the wrist capsule. They don't. They're not involved in any sort of sensation in the hand or fingers. They just transmit pain from the wrist. The procedure basically involves cutting these 2 nerves here in this part of the forearm, which takes away about 50% of pain from the wrist joint. This can sometimes be done along with something called a wrist arthroscopy, which involves putting a tiny camera into the wrist, which is this image right over here, and allowing one to shave away part of that radius bone that's arthritic. You can only shave away a small part, but it can help with the pain. The most common scenario where I utilize this is patients that have still well-preserved motion in their wrist, but it's painful and they still have a lot of functional demands. Examples in Boulder would be patients with slack arthritis that still climb and ski and bike and wouldn't want to lose wrist motion, but want something to alleviate pain. And this procedure can buy some time. Other surgical treatments out there are something called a total wrist fusion or a total wrist arthroplasty. These are usually reserved for scenarios where the entire wrist joint's involved, both the midcarpal and radiocarpal joints, or where prior procedures that I mentioned, like a PRC or four-corner fusion, have gone on to become arthritic in the joints that were preserved. The fusion I would consider more as a salvage procedure because all motion of the wrist is now eliminated, you can only rotate. It is, however, effective for pain and instability. Another procedure that's also available is something called a total wrist arthroplasty, which is similar to a knee or hip replacement. Thank you.
Okay, hello. Thank you, Dr. Rog. That was a great deal of information, and it leads into my role, which is an occupational hand therapist. I'm the individual that works directly with the patient before maybe they've seen Dr. Rog, and then, of course, after he's done surgery, I would be involved in that. I'm Ann Brexa. I'm an occupational therapist, and I've been practicing hand therapy with my colleagues at Boulder Community Health, South Boulder Road, the Lafayette Community Medical Center Clinic. And I've been seeing patients there for a variety of different hand and upper extremity challenges. But today I'm here to talk to you mostly about exercise for patients who specifically have arthritis. Hand therapists work very closely with hand surgeons. Oftentimes we'll see patients who come in because they're complaining of some joint irritation, joint swelling, joint pain, and we'll do a preliminary evaluation of the hand and upper extremity, and depending on what we find, which is not always arthritis, we often will then make a referral on to the hand surgeon, because the diagnostic testing and assessment of the surgeon is really an important part of us being able to perform our jobs. Arthritis, pain, and inflammation starts early. I often see patients who are in their as early as their late 30s, early 40s, into, of course, their more senior years. But with the onset of early signs of arthritis, as Dr. Rog said, sometimes it's not that early. It might be more advanced by the time you start showing symptoms. But my objective is to teach you today just some basic range of motion exercises that you can begin to just keep those joints mobile and active, but it's not going to prevent the progression of the arthritic condition. So occupational therapy and hand therapy is a rehab resource to address the functional, how you use your hands. These are your tools. It's how we manipulate our environment. And those tools can get rusty and overused with time. And we identify that as, the progression of breakdown of the joint, which is the arthritic process. I see patients in the clinic who may begin with these early signs, but I may also see people who are at more of an advanced level. And then I see patients after they've seen the surgeon and are doing post-operative care. It's recommended to address your symptoms early when you start noticing them. A lot of times humans tend to just let things go and think that they'll be able to manage it, or they'll just wait till it gets maybe a little more advanced or worse. I highly recommend that it's worth a visit to see the surgeon, the hand surgeon, or to see a therapist for an early assessment and just learn some education and understand what's happening with your joints. And you don't have to do a long course of treatment or intervention, but at least to understand what's happening and learn some early strategies. Today, I'll be demonstrating the range of motion exercises that can be useful for you to maintain your joint mobility. With advanced arthritis, exercise is not enough. It's important to maintain, but there's much more intervention that needs to be done, and you heard about that in Dr. Rog's procedures. I'll just give you a brief overview of what might happen if you came for an occupational therapy evaluation. You would have a comprehensive assessment of your hands and upper extremities all the way to the shoulder. We would make an assessment of where the problem lie in your extremity. And related to arthritis, a few of the things that we would intervene with is we would incorporate exercise, and that could be both range of motion and some strengthening. Joints and hands become weak over time, and it's always beneficial to incorporate a program of strength and range of motion. We use warmth and heat to address arthritic joints. That could be a rice bag. It could be warm mitts that you put in the microwave. It could be warm water soaks, and those are really helpful for modulating some of the arthritic pain, and also can help increase blood to the tissue and make mobility a little more improved. Dr. Rog did address splints and braces, and I think those play a huge role in addressing problems associated with arthritis. Again, it's unique to which of your joints are involved, how far the progression of your injury is, what your activity level looks like. It's not really a one size fits all. That's why I really emphasize seeing a specialist for some of that professional perspective. Another important part of outpatient hand therapy treatment is teaching you how to protect your joints and conserve your energy so your tools last. It's not uncommon for us to overuse this pinching mechanism, which Dr. Rog talked a lot about, the carpal metacarpal joint. And so much of what we do is using our tools repetitively. And there's a lot of different alternatives to be able to perform activity while still using your hands, but not loading the joint. We have numerous pictures, resources, educational tools. So that's an option to learn a little bit more how to protect your joints and make them last. Lastly is adaptive equipment. Probably anybody who's shopped on Amazon or looked at online resources, there's many tools that increase the grip size of handles that you use from brushing your teeth to using a knife to manipulating scissors to gardening tools. All of those modifications in the tools that we use every day with our hands can help reduce the load on the joint and still allow you to be independent and functional in your daily activity. So I'm just going to move into a list of 10 exercises that are safe and useful for most individuals. And you don't even have to have arthritis to do these. They're just good to maintain the flexibility of your joints. What we say is motion is lotion. And what that does is the more you move your joints, you increase the synovial fluid, which is the lubrication within your joints, and prevents you from getting as stiff and immobile that accompanies the condition of arthritis. Okay. There was a handout attached to this presentation, and you can print that later and reference it. So there's pictures that you will have access to that accompany the demonstration I'm going to do now. So the first exercise that I'm going to do is wrist bends. I like to start with the bigger joints rather than the smaller joints of the fingers. And this first one is quite simple. It's just bending your wrists forward and bringing your wrists back. I'm going to turn sideways because I want to emphasize elbows straight, shoulders back and down, and hand and palm straight. And just gently bring your fingers and wrists forward and get a little stretch. You'll feel it over the top of your extensors. And then bring your wrists back up, keeping those elbows straight and shoulders down. And you can do that repetition 10 times. Okay, that's wrist flexion and extension. The second exercise, nice for just maintaining fluidity in your wrists. Your wrists have multiple mobility positions, and this one is just wrist circles. Again, shoulders back and down, arms relaxed, and just move your wrists in a nice fluid circular motion. It should feel comfortable. You shouldn't have a lot of pain when you do your exercises. You may have some pain, and one of the goals is for the pain not to worsen, but for actually, hopefully for the pain to lessen the more you start gaining a little bit of mobility. So wrist circles is number 2. Number 3, we're now going to move into the fingers. This exercise is finger stretches. And assuming there was a table here, you would just put your palms down on the table and just spread your fingers apart. Hold 5 seconds. Bring your fingers back together. Stretch your fingers apart. Hold, bring them back together. What you're aiming to do is to retain the mobility that is natural in your joints. And if you're starting to develop a little bit of stiffness, this may counteract that. Okay, number 4 is you're going to put your palms on the table. And this exercise is addressing the metacarpals, the bigger knuckles here. And we're just going to look at raising each joint, thumbs, or each digit, thumbs, index finger, middle finger, ring finger, and small finger. And you can repeat that 10 times. And you're just aiming for a nice, comfortable stretch. Okay. Next is the thumb exercise. And a lot of these exercises really need to be addressed to address some of the changes that are starting at the carpal metacarpal joint that Dr. Rog talked about. And this one is with your palms on the table. You're going to try to bring your thumb out as far as you can, so you're getting kind of an L position, and then you're going to hold that with your muscles, and then you're going to slide that thumb back in again. Slide your thumbs out and slide them back in again. Your goal is just to achieve maximal range of motion. Again, avoiding pain if at all possible, but it may be a little painful if you have a progressing condition and you're just starting up with these. The next one is to retain the mobility in the thumb and keeping that carpal metacarpal joint stretched out functionally. When we use our hands, we use our thumb and our index finger, And we don't want to have a flattened thumb. We want to try to maintain that abducted, opposed, rounded thumb. So go ahead and take both hands and make a circle rather than a flat. So make it circular, hold that, and then open. Make a circle, hold, and open. 10 times is another good repetition. I reverse these. The next one is to just make a C. So the C position is just paying attention to wrist straight, thumb out, curl the thumb and the fingers in a C position. I hope you can see that okay. Open, curl that thumb into a C position. Okay, next one I call the joystick, kind of self-explanatory. You're going to put your hand into a gentle fist and bring your thumb up. And again, there's a tendency for the thumb to kind of start to tighten as those ligaments shorten, as the joint loses its stability. You don't want to yank on it, but you want to put your other hand around your thumb, gentle warmth, and guide it out as if you're operating a joystick. Don't pull on it, just gently hold it and give yourself a gentle stretch. And then you can repeat on the opposite hand. Make a gentle fist, thumb up, take your opposite hand, the warmth of your hand, and just gently hold the joystick. 5 seconds, relax, and you could repeat that one 10 times. Okay, another one is thumb rolls. These are the fussiest of the ones I'm showing you. What you're going to do is put your hands into so the pinky is resting on the table, fingers are loosely flexed into your hand, and you're going to kind of just gently roll your thumb and roll it back. It's fussy is the way I say it. It's just a slight movement, but you're getting mobility through the extent of the thumb and preventing some of that soft tissue tightness that occurs. So go ahead and try that one. And then the next one is pinky slides, but actually it's the thumb sliding. I call it thumb slides because you start with your thumb reaching over to your small finger. And that can be painful for some people. Hopefully you're getting to these exercises before it is painful. So go ahead and take your thumb and roll it over to your small finger and just gently slide it down. If it feels a little stiff, go as far as you can, don't force it. Often what happens is the more you do these exercises, just like with all the joints of your body, things start to loosen up a little more. So there you go. You're sliding down each digit and you're starting with your pinky. Lastly, my tennis ball. Lastly is this tennis ball exercise. And I just caution you not to squeeze it, but just to place the tennis ball in that C formation of your hand and just give a little pressure. Hold 5 seconds and relax. If you have advanced arthritis and there's changes in your joint, which many of you may already be experiencing, you want to be careful with this because the ball might not fit properly in the normal position of your hand, and it could be stressful. So if you don't have any joint changes that you're aware of, go ahead and do this one. Gently hold and squeeze and relax. And you can do all of these 10 times. There you go. That's just primer on early hand exercises, and you can do these throughout the course of the day. You know, when you're thinking about it, you can stop and just do a few of the ones that I showed you. You don't have to do them all, but keeping the body, the hands and fingers moving is valuable. Okay, those are the exercises. Thank you.
We're going to bring Dr. Rog back up and have both of the speakers available for the audience questions. We want to remind the audience that now is the time for Q&A. And if you have any questions, please put it in the chat box below the video on your screen. We do have a few that have already come in, and we'll ask these in no particular order tonight. Is there any link between menopause and hand arthritis?
I think there's a link temporally, certainly, and there most certainly is some connection between hormonal changes and certain types of arthritis, especially the thumb CMC arthritis we keep talking about.
Okay. Anything that can be done about that while you're in menopause?
I think I don't think there's anything specifically to be done about the menopause part as it's related to arthritis. I think all the treatments and exercises that Ann talked about, that I talked about, I think as far as hormonal driven treatments, probably more of a question for your endocrinologist.
Okay. This person had their right CMC joint replaced. Now their right hand is very, very weak. If they have a replacement of their left thumb joint, will that hand get weaker too?
I'm assuming with that question that replacement means the trapeziectomy procedure. That's usually what that people refer to. An actual replacement is pretty rare for that joint. All of these surgical treatments have their outliers. None of them are perfect. You strive for the best outcome, but some patients may end up weaker than desired. And I think it's certainly possible that the other hand can feel the same way. It's hard for me to answer specifically to your question without knowing the technique used or seeing why it's weak. There's a lot of reasons why a thumb can feel weak after that procedure. Sometimes I mentioned that these techniques are utilized to try to keep the thumb suspended. Occasionally that doesn't work, and if the thumb slides down, it can contact the next bone and cause issues which can result in weakness. So there's, I guess, a lot to unpack in that question. There's probably there could be different reasons why it feels weak, and that may not be the case if you have it done on the other side.
Okay.
So I'd recommend having somebody evaluate why that happened on the right side to see if that would happen to the left.
Yeah,
Could also be a therapy related.
Yeah, I would support that. Have it looked at to determine possibly why that weakness exists, because often after that surgery, your strength may not be at what its prior level of function was, but it certainly can be strong enough to be quite functional, and it wouldn't be so weak that you were, impaired. So I think it's worth following up.
Okay. Yeah, and we do want to remind our audience that they can make appointments with these people after the presentation tonight. They would welcome seeing you and addressing anything specific to you as an individual. This person has a trigger finger in their left hand. Is that a form of arthritis?
Fortunately not. It is also one of the most common reasons people see me and maybe even see you. So it's just a very common hand complaint, but it's not an arthritis problem. It's actually an inflammation of a flexor tendon in your hand. The flexor tendons run in a tunnel starting at about here, And sometimes if that tendon gets swollen, it actually just gets stuck in that tunnel and causes that tendon to catch. It's also effectively treated with an injection, with therapy, but it's not an arthritis problem.
But there's definitely avenues to address the problem and improve it and correct it by seeing a therapist and a surgeon.
Okay.
There's also a surgery for it. It can be done in the office. Not everybody needs one for it. It's a common problem, just for not an arthritis problem.
So even though it's not arthritis, I'll follow up with a couple of the sub-questions for this person. They've received a couple of cortisone shots. They didn't know how many shots were safe to have. So
I'll go with that one. Everybody has different opinions on the numbers of shots and what can or can't be done. I don't have a specific number I use for people. I do tell patients that once you reach there was a study done that showed that once you reach 3, the chance of it recovering completely after about 3, if you have 4, 5, 6, go down significantly. So you reach this kind of cost effectiveness point at about 3, where it becomes more reliable to seek the surgical solution. For this particular location, I don't think anything has been proven that it's unsafe to have more than 3 or 4. It just becomes eventually kind of futile because you keep having them and then the problem keeps happening.
okay.
And from a therapeutic point of view, oftentimes we can provide a little splint to rest that area and teach people how to stretch that tissue and address some of the functional problems and modifying how you use your hand in activity. If it's so advanced and it's recurring, kind of time to see the surgeon, and the surgeries can be really effective.
Yeah.
Okay. Any recommendations for slowing down arthritis progression?
If somebody finds that, they'll be billionaires. I don't think there's anything medical to slow down the actual progression. I think there's ways to slow down clinical or symptomatic progression, though. And a lot of those are Ann mentioned exercises to maintain range of motion. Arthritis makes joints stiff. If you maintain the range of motion, then clinically you're slowing it down. What I mean by clinically is you're not showing the symptoms of a stiff joint, even if the x-rays may show that. But to keep osteoarthritis from happening and from stop this complete progression, nobody has that answer, unfortunately.
So nothing dietary or anything else that's recommended besides the exercises?
I think there are dietary ways to treat symptoms. I think addressing inflammation, an anti-inflammatory diet, but I think that's all addressing symptoms rather than actually slowing down the process from happening once it happens.
And I would say that depending on your activity and how you use your joints could maybe aggravate or contribute to furthering the problem as opposed to protecting and retaining the function that you do have. And that comes from education, modifying your activity, joint protection, etc.
And again, I think it's important to point out that this is just an overview of osteoarthritis. That answer is completely different if it was rheumatoid arthritis or arthritis caused by gout, because there are medical treatments for that, for all those. You can stop that arthritis from happening. There's a lot of effective treatments for that, but that's a little bit out of the scope of the talk.
point.
That's why there's a whole field called rheumatology that involves doing that.
Okay, thank you very much for that clarification. This person said at times their fingers get locked in place. Is this advanced progression of OA?
It almost sounds like a trigger finger question again, so I suspect that may be the problem. You occasionally can get some symptoms of locking with osteoarthritis, but I guess I'd have to see it.
I would say that's not a common presentation for osteoarthritis. And there are really kind of some obscure conditions where fingers lock that aren't the classic trigger finger locking as well. So I think that's a really good opportunity to maybe seek medical attention and get a better assessment.
Okay, perfect. Thank you.
Locking can happen more often in larger joints, shoulders, elbows. When you have a loose body, that can cause a sensation of locking. I don't see it very often in smaller joints. There's plenty of soft tissue reasons why locking can happen, but usually not in arthritis.
Okay. Generally, how long does it take to get back to work if you have a trapeziectomy surgery with the job you were on the computer all day?
Depends on how much you can do with your operated hand for your job. If if you can type with the thumb immobilized, I'd say a few weeks you can get back to that sort of job. Especially if you're able to use technology such as a dictaphone, you could probably do quite a bit pretty soon. What do you think?
I would agree that there's a lot of different ways to skin a cat, so to speak. Modifying how you go about returning to work. You are not going to return in the normal capacity that you were at while you're going through the recovery process. But your fingers are free, your thumb's not. And certainly many people resume doing their work before they're completely through their rehab process. Depends on the demand of the job and how you modify and approach it.
Right. Okay. This person's trapezoid is starting to rise up, and sometimes they wake up with what looks like a blood blister and redness. How soon should they consider having hand surgery? And they're also allergic to some of the steroid treatments.
That one, I'd probably recommend having someone check that out. That's not a typical symptom of arthritis that's being described. So I think it may be something benign, but I'd have somebody check that, have your hand checked out.
Okay, perfect.
I would agree.
You kind of went through this, Anne, but do you recommend squeezing a tennis ball?
Well, I would recommend, it depends on your condition, but as I pointed out with the tennis ball, it depends on what the status of your joint is. And if your joint has some beginning deformity, loss of stability from some of the soft tissue changes, squeezing is not the best thing to do, but just maintaining your range of motion.
Is it okay to do these exercises prior to an evaluation to see if they work, or is it possible that that could cause more damage?
I would suggest trying these exercises. I chose a set of exercises that are rather benign, and they're mainly just to maintain the motion in all your joints, which is what we want in our daily activity. So unless you have pain with any of them, or if there is pain with any of the exercises, maybe eliminate that one, but go ahead and try these exercises. That was the purpose of the presentation today.
Okay. We've asked about foods. Is there anything with supplements? This person wanted to know specific with swelling.
I think several of the supplements I listed were aimed at decreasing inflammation, such as turmeric. So I think if you want to educate yourself on supplements, then look up the kind that address inflammation. So certain ones may not address swelling, but those that have a positive impact on inflammation may help with that.
Okay. This may be outside of the scope, just let us know. How often should you get tested for rheumatoid arthritis?
A common scenario for rheumatoid arthritis would be swelling, and specific to the hand would be swelling in these joints and these joints. That is often worst in the morning, and it can last a while. All joints feel stiff in the morning. Mine feels stiff in the morning, but they warm up right away. If that lasts you an hour or two and they are visibly more swollen, then you should just get tested. There's not really a frequency of how often. If you display some of the symptoms, then I would get it checked out. There's fairly specific symptoms to rheumatoid arthritis that are very different from osteoarthritis, and that have even your primary care doc look at, hand surgeon, a rheumatologist, but you don't necessarily have to have it repeatedly tested unless you're showing the symptoms of it.
Okay. I'm going to ask a couple of quick questions here to wrap us up here. Is Voltaren significantly absorbed systemically, and is it safe to use when also taking Eliquis?
Good question. I would say generally yes. I always defer to patients' cardiologist or primary care doc to ask that question, but the systemic absorption isn't that great. So most of the time when I've asked cardiologists, and they've said yes, and that's many times. So not too much systemic absorption.
Is crochet bad for hand arthritis?
That one.
That's in my territory. I'm a fan of people doing what they love to do and using their hands. I'm also a fan of paying attention to how you do the activity. So that's kind of twofold. If you're crocheting for maybe 15 minutes at a time, and then you stop and take a break and do your exercises, and then return to doing some crocheting, and then balance it with other activity. Prolonged repetitive tasks really are not great for arthritis. So if you did crocheting for hours on end, that would be contraindicated. But I would highly encourage you to continue crocheting and just change the approach in how you do it.
Yeah, and I'd add on to that, and I didn't mention this much in my talk, but arthritis can kind of flare too. So it doesn't always occur at a baseline. So if you're crocheting and suddenly you have a project to finish and you're doing it for 5 hours, your hands can swell. They can become stiff. They can become painful. So those are situations where you got to take a break and bring that down. So it can happen episodically too. Mm-hmm. So I think balance is important.
Last question. This person has arthritis with very little pain, but they do have deformity. Who do they see of you guys first?
I would say see you first.
I think that's a good point. Yeah.
Because and you could come see me first. Often patients come to see a therapist first, and really we complement each other. And if you make it to me first, you will most likely eventually go to see the surgeon. And if you see the surgeon first, you would probably refer back. But I'm just thinking they do the diagnostic testing and the images is what I'm saying.
We'll look at x-rays together. Yeah. But I would say if you don't have pain and you have a deformity, I'll educate you about what's going on. I'll show you the x-rays, but I won't talk you into a surgery.
Correct.
And if you don't have pain, you don't need anything aggressive done. But I can show you an x-ray and tell you what's happening or why it looks the way it does.